Morning, everyone. For me, the weekend has just started. I realize that the weekend is sort of a very flexible concept for many people right now. But I would like to go over some data with you. This time I don't have much new data. What I have is very old data. It's 100 years old. And yet there are some lessons we can learn from the 1918 flu about where we are right now. I would like to point out that where we are right now, today's Seattle Times has this headline on the front. I was a little bit disappointed to find out that the biggest headline is about politicians calling each other names. I was more interested to open it to the middle and to find out this headline right here. It's going to be a little bit small in the window. The IHME model, can you see that? It predicts that for our state, May 18th will be a safe reopen day. I think it's probably pretty close to right on and probably a little bit pessimistic, just like it has been all this time along. Realize that these models are trying to predict what the shape of the curve is going to be, and they're good for different things. The IHME, most of all, was trying to say where would our resources be most in demand. It was trying to predict the peak, looking forward onto the peak. And so I want to say, when we're trying to predict what's going to be happening next, we can see the track record of these models, and the IHME model has been over-predicting some of the resources that we would need. Some people are like, well, why should we believe it at all? But if you have a storm coming at yourself, and the storm has a cone of uncertainty, and the storm has veered, I say this from personal experience having lived in Florida, when the storm veers off, you don't complain about the weatherman not being certain that the storm was going to hit you. The IHME model previously was about when the storm's going to hit. I have to look at this new model and see how much I want to put stock in it about when it says that the storm is over, the storm has passed, and the risk is enough to be able to open up. My feeling is that, again, it's probably a little pessimistic, but I don't mind being a little pessimistic here, and May 18th sounds, at least it's not the end of May, like some people were saying recently. That sounds reasonable, maybe a little pessimistic to me. Another thing about this virus is probably going to hang on for a while. It's probably going to hang on longer than we expect and longer than the IHME original model predicted. This also goes with my friend in a hospital who has seen fewer people are dying than he expected, but they're also on ventilators for longer than he expected. So this is a stubborn virus. We've got to see what happens and collect the data and then base our decisions based on that. And so I have a lot to say about that today, but what I'm going to say comes from 1918. You've probably seen some data from 1918. Usually you see one or two cities being compared. And it's the nature of social media that you have to limit yourself to only one or two cities. I think it's more important, though, when we're trying to answer a question this big, to look at as many cities as possible. So I went back to the original paper that was comparing those two cities, and I found out they had 16 cities in there. And those 16 cities tell a much more robust story than just two of them. So let's take a look at that. Now, 1918 is probably the best historical event to what's going on right now in 2020. Both of them are new, both of them are respiratory. They're different viruses and they have different kinetic parameters. That means that they infect at different rates and they affect different people. But you can see that the parameters are kind of similar. 1918, the average course of infection to death, in the paper that I was using that they were modeling, they put 12 days from infection to death. And the R0, which is a measure of, it's an immunological number. Basically, you want this to be below 1, and the higher above 1 it is, the worse things are. The R0 was 2. COVID-19 is longer than 1918. Part of that is that we have more medical facilities and things like ventilators to help people fight this thing off. 18 days is how long it takes from symptoms to death. So you see it lasts longer, and it's more infectious. The R0 is 3. And that's going to have a big impact on what we're talking about. But it's good to know these things. They're very different in age demographics. The 1918 flu is pretty complicated, but it did have a wave where it was affecting younger people more. This 2020 flu is different. It's got a typical age curve in which the older you are, the more at risk you are. And so the 1918 flu, because it was novel and respiratory, it's a good model of how when you don't have pharmaceutical inventions, you do what are called non-pharmaceutical interventions, which basically is social distancing, washing your hands, wearing a mask. What kind of things that you can do that are not specifically tailored for the disease and yet will prevent its spread nonetheless. So these are called NPIs, and it's going to be a theme of today. So there's actually two papers. They were back-to-back in Proceedings of National Academy of Sciences. They analyzed 16 cities, and what we tend to see around is we see one of those cities being put up, and we say, this city is an example. This is what you might have seen a version of this. And this is from this paper. By the way, it's been miscited, so it's been a little bit hard to find this paper. Nothing I haven't seen before, but it's important. Scientists out there, make sure that you have your reference section right, because this has been miscited, and it took me a little bit of digging to be able to find it. If you want people to find the research that you base your work on, make sure that your reference section is right and doesn't have a typo in it. Okay, little rant over. But the thing that you may have seen, and I've talked about this on a previous podcast about a month ago, is Philadelphia versus St. Louis. The idea is that both are similarly sized cities, and they both had cases of the 1918 flu about the same time. Philadelphia had its first case here. This is date on the x-axis. St. Louis had its first case there. But they both implemented distancing at the same date. That means that St. Louis implemented distancing much earlier in the course of its infection. Philadelphia had things like a parade, so the opposite of distancing. And you can see that the death rate from the 1918 flu in these different cities was very different. So I went and I covered up the curve. Not only was the curve higher for Philadelphia, the curve was shorter for St. Louis, but also it was spread out. So the question is the area, is the total pain of the flu actually brought down? Were there actually fewer deaths overall, or did you string them out longer for St. Louis? Well, you can do a rough estimate of that by finding the area of each of these, and I put triangles over. And yeah, 27 triangles were for Philadelphia, 16 triangles for St. Louis. And so that means that St. Louis reduced the load of deaths by about 1/3 relative to Philadelphia, but they also made it last twice as long. If hospital capacity is a line on this graph, then you can see how Philadelphia, in this theoretical example, would have exceeded the hospital capacity and would have had even more death as a result of doing that. By the way, the hospital capacity is just a theory. It's just a line that I'm putting on there to try to show how this relates to us. The interesting thing about St. Louis, though, is also notice there's more triangles on the right side of this graph. The triangles, the second wave, is bigger. And so where does that come from? That comes from another paper that this was related to that actually compares 16 different cities. And in a sense, the Philadelphia versus St. Louis example is sort of cherry-picked. It's sort of the two extremes from the 16 cities of what's going on. One of the important things to note is that when we're showing just one or two cities on social media, we're cherry-picking the data, and we're trying to make a point. And I see where that comes from, but I'm also like, if we have 16 cities, let's go back and look at the 16 cities. Now, each of these has an interesting sort of pattern, and in the green line, they show what would have happened, what they project would have happened if nothing was done. In every single city, there were non-pharmaceutical interventions that were put in place. The question is when and how long were they maintained? Well, they show how long they were maintained with the light green bars. Let me zoom in here. Here's Philadelphia and St. Louis. You can see that the data looks the same here. St. Louis is predicted to have a big peak, about as big as Philadelphia for the first time, and yet they brought it way down by having that light green horizontal bar that shows their non-pharmaceutical interventions. So Philadelphia encountered a lot more death. But look what happened with St. Louis. St. Louis had a second wave, and in a sense, they actually brought down the 1918 flu too much. This is sort of complex. Make sure that you stick with me through the whole thing for the whole argument. But the paper itself says that St. Louis distanced too much for the 1918 flu causing a second wave to happen. And the second wave was actually higher than the first, and they needed non-pharmaceutical interventions more than the first. This is what the paper exactly says, and so this is not cherry picking or hindsight bias, because this is what they said in 2007. We've got to figure out how to apply this in 2020 with a different virus with different kinetics. They show over here, by the way, some sort of model on the right side of this, above my head, where they talk about, okay, green again on this is what happens in a general generic city if you don't do anything, no non-pharmaceutical interventions at all. You get a big peak, way too big. If you do optimal pharmaceutical interventions, for the 1918 flu, you could bring it about to, you could get the population to be 50% infected. That's the point where you have a R0 of 2, and you actually have the population immunity start to kick in. If you did it exactly right, you can get one wave where you get 50% of the people infected, and you get no future wave. If the controls are what they call too effective here, then you end up with two waves. The first wave is 33% infected, and the second wave is another 33% infected. And in fact, it looks like St. Louis even was a little bit below that. They maybe had 25% infected on the first wave, and then they ended up with, 40% infected on the second wave. I don't know how the math works out. But you notice how those add up to be slightly more than the optimal situation. Now, the other thing is, looking at all the cities, not a single city was able to hit the optimal situation. It's kind of like you have to pick your poison. And if you're going to pick your poison, don't go for the no controls line. Go for the too effective line. And that's our strategy right now. But we've got to realize that out there, for this particular historical situation, there was such a thing as too effective. Also, the thing that people say, if we distance a lot now, we won't have to distance later. Well, St. Louis distanced a lot first, and then they had to distance later. It's the nature of the disease that it's not like you have to put in your time, and then you get free once you put in your time. You have to put in your time in the sense of how many people get infected and how much the disease spreads until the immune system takes over. Or, and here's the hope here, you put in your time so that you can test and isolate and have targeted non-pharmaceutical interventions, and then you can develop pharmaceutical interventions. And that's what clinical trials and vaccines are going on right now, but those are going to take time. Right now, we're still in the non-pharmaceutical intervention stage. So notice that for St. Louis, the second wave was indeed bigger. And if you're going to be cherry-picking the extremes of data, it's worth it to point out that St. Louis did have this kinetics, this time course for their infection. Remember, though, that the 2020 flu is different, and we're in a different situation now. But don't say things like you can't distance too much. St. Louis shows that you can actually distance too much, and that's specifically what they said in the paper. I want to go back and I want to look at some of the other ones. San Francisco is cited in the paper as they actually were about to get the R0 below 1. It looks like if they had continued to distance, they could do that R0 below 1. And so they could have possibly stamped it out. Now, of course, they didn't have testing or things like that, so it was probably going to come back no matter what in 1918. But using 2020 technology, it's possible that San Francisco shows how you can distance a lot, get the R0 below 1, and then have it in a position where you can really knock it out with a lot of testing and a bit of care when it comes to relaxing social things. But San Francisco had a second wave. New York is the closest one to optimal. You see that they had a bit of a second wave, but it was very small. And it looks like they got about pretty close to 50% infected the first time. 2020, the New York situation, because of the kinetics of this disease, totally different. And so it's important to point out the difference between the different situations. But New York and Newark are about as close to optimal as you'll get in this messy sort of world. And I have to also show Spokane was shown on this. Seattle was a candidate for this, but they had evidence only for when Seattle put restrictions in place. They didn't have any evidence for when Seattle lifted the restrictions, so they couldn't put that green bar and they couldn't use it for one of the 16 cities. Okay, so all that's to say that Spokane looks like St. Louis, but it's possible that Spokane kept it below the line that we're all worried about. Spokane is an example of keeping it below the critical care capacity. And again, that's the main thing we should be worried about. Cases are one thing, deaths are another thing. The thing we have to keep focused on is, are our hospitals able to handle this, both in terms of number of patients and in terms of keeping them supplied with PPE and with pharmaceuticals. The other paper that talks about the different measures and which different measures worked best, okay? And they sort of examined all these 16 cities. They actually examined 17. I'm not sure which one is the one that wasn't shown on the previous graph, but whatever. They have all these different things. And if you have a screen big enough to read this, they have school closures, church closures, they have dance hall closures. And again, school closures are going to be slightly different in 1918 than they are in 2020 because of the nature of the age demographics of this disease. Nonetheless, we can say for 1918, was one of these better than the others? Okay? And the answer is no, but the more the better. The answer is not quality. It's not like there's one of these non-pharmaceutical interventions that does much better than the other ones, but there's quantity. So basically we're at the point right now where we're restricting all we can. And what's interesting to me is there's going to be a lot of argument about which ones can we lift when. This would seem to argue the important thing is to keep some of them and remove others. So you can say not what is going to be most effective at stopping the disease, but what's going to be most beneficial for our community to relax rather. But we need to keep some of them in, by the way. But which can we relax? If it's just a matter of getting a number of them, and the more you do it, the more they're sort of additive in that sense, then that's a sort of good news because it means that we can pick which ones we want to keep implementing. Again, 1918 data, but this is what it said. They didn't find one non-pharmaceutical intervention that was much more useful than the others at preventing the spread. And again, no city got it right. I want to show you the exact part of the paper that says you can restrict too much, at least for the historical example of the 1918 flu. Remember, this was less transmissible than COVID-19. It started off around 2.0 as opposed to COVID-19 being 3.0. By the way, you might have heard something about one study came out that it was like 5 or something like that. That's an example of headlines taking one study that took one weird assumption and got a weird result out of it. A lot of people have been looking at this, and I'm still convinced by the vast bulk of the other studies. Rather than, the way science works is not that you have the one brilliant scientist that sees something no one else does, and then they have the model that's right, you know, if there are not of 5. The way science works is that you have a bunch of different labs doing things slightly different ways, and they get the same result. And that's what's happened with the R naught of 3, and that's why I trust it. So, I want to read you exactly what they say. In the cities that saw double-peaked autumn epidemics, control measures may have been, if anything, too effective, stopping transmission so effectively that substantial numbers of susceptible individuals remained in the population when controls were lifted. The theory of imperfect interventions tells us that there is an optimal middle ground. There are interventions tuned to give a single peak of minimal size. It appears that no U.S. cities found that optimal point. The cities that got closest to the theoretical maximum possible reduction in mortality were those that implemented both early and effective interventions throughout the first peak, and then were able to reintroduce these when transmission again increased. It looks like that's our situation. So we need to be talking about which interventions can we live with, and which interventions are doing the most damage to other parts of life. Because we can do a complicated response, but we can relax some of them. And there is such a thing as being too restrictive. You may have seen the example of Singapore. I do wonder if Singapore is an example of being too restrictive. By the way, we are not there, okay? We have not been too restrictive yet. So the way the numbers relate is, again, R naught of 3 for 2020 relative to R naught of 2. And that means that the optimal infection was not 50%, it's around 66%, or I'm going to round that to 70%. That's a lot harder. In 1918, it also shows us that in 1918, they were stressed out by these non-pharmaceutical interventions too. They were only able to maintain them for up to 6 weeks. And so historically speaking, probably after 6 weeks, you've got to relax something. You've got to figure out what to do. But we do have a more serious situation in terms of what happens when we relax with the second wave, because we are much farther from population immunity. So if 70% of population immunity, if the path to getting that overloads the hospitals, then that's the thing that we need to avoid at all costs. And so our choices are more limited, because it doesn't look to me like we can just open things up and let population immunity take its case. The science here is saying that we need to keep restrictions in place. But it's also saying that if we can keep R naught below 1, then the infection will die out. Then again, it can be imported back in. But if we have comprehensive testing, and if we have an ability to isolate the new cases effectively, then we can have hope of keeping that R naught below 1. Testing can help us bring down the R naught. Non-pharmaceutical interventions can help us bring it down. And here's the graph that shows for King County and Snohomish County, the R naught has dropped from being about 3. Again, that's the number that I'm using for the unintervened R naught. And then it's brought down, and you see the line of 1, and you see all 3 counties on this graph are below an R naught of 1 by March 25th. That's really good news. And we've seen cases go down. And in the drop-off graphs that I have, you literally see the cases dropping. That is a sign that R naught is below 1, because that when R naught's above 1, cases keep growing. We've avoided that. So good. We're here. Stage 1, we've done it. But now what does stage 2 look like? So the one thing I want to say is I'm a scientist. Put some numbers on it. I see a lot of things going around, and I hear a lot of the same things from different people. But until you put numbers on it for saying, this is what we mean by hospital capacity, this is what we mean by declining cases, then we can't really talk to each other until we have numbers to discuss. So we have this R naught number. The R naught is good. And so we can relax it and see what the R naught does. We need to say that cases are going to go up. The main thing that we need to see is cases need to go up a little bit in some ways because we can't prevent it. And so it's not like we should be perfectionistic about it. It's hard to talk about. And you see how I'm worried about like some part of my comments being taken out of context and being say, oh, we don't need any restrictions anymore. But the thing is to keep your eye on the ball and remember that the data that matters most is not cases on the one hand or even deaths on the other hand. Even deaths have problems with reporting. But in the middle, the critical care crisis, are the hospitals overwhelmed? And we have to be in communication with the hospitals, trust the hospitals, tell us what we need. And overwhelmed does not just mean hospitalized patients, but also needs the supplies and the work hours that they need from our people that are working there. Cases are an early warning system that the hospitals may become overloaded. But that's how we have to use it, as sort of a canary, rather than saying, oh, we aren't going to be happy until cases are 0. Viruses don't get cases to 0, especially infectious ones like this. So cases and even deaths are problematic and inevitable data. Deaths are inevitable. The question is excess deaths. The question is deaths in the context of our whole society. And so I've seen some tweets going out about like states, these were cherry-picked. They took the states that they wanted to make a point about, and then they said, oh, deaths are rising a huge amount in these states by a percentage basis. Well, that doesn't really say what you think it says necessarily. If you have a really low number of deaths, when it hits, you're always going to get like a 200% increase. So be careful with how you use numbers. Cases are now rising in rural areas. That worries me, but I also wonder about how the kinetics are going to be done when people are already distanced in a certain way. Different age demographics could be better, could be worse. The thing is, don't assume that you know what's going to happen, that these people are going to be hit by a wave. We've had some situations. The Bay Area was expecting a surge. They never got a surge. So just because you think it might happen, we have to collect the data on what's actually happening. And the data we have to focus on is critical care capacity. We can send some critical care capacity in the sense of sending some doctors to New York to help them now, because there are some places that are not as hard hit as New York. That's the way we should be talking about it, instead of saying, oh, we all need to relax or we all need to freak out. We need to help. It's a dial, not a switch. I've seen people from all over the political spectrum use this, and this is completely true. So we need to dial up the areas. We need to relax the dial on those areas that will let the most people work, because the other number that we see that is huge right now is unemployment claims. We need to figure out something to do with the huge amount of debt that's being incurred. People need to eat. We need to figure out how those food banks are going to work with the huge long lines to them. That's data to consider as well. And so we can start dialing up, and the good news is the non-pharmaceutical interventions, they all work. And so we can take off a few of them when it's time to relax, and we can decide not is this the most effective pharmaceutical intervention, because they're all effective. But the question is, which is the one that will get us the most help for these other areas we have to consider? So we know more about this than in 1918. And the more we know is good, because we can come up with pharmaceutical interventions. But it's also bad. It has a bad side to it, because we can worry more. We can say, oh, I think the Bay Area is going to spike in cases. But it never spiked. So worrying about hospital capacity being overcrowded, we need to prepare for that possibility. But I see a lot of worry and even despair because we know so much more about this, because we can detect the cases wherever they are, in many cases, despite the fact that it's complicated and there are many cases that we are not detecting. So I'm reminded of how the tree of knowledge of good and evil was the whole problem at the beginning of history. And I wonder sometimes, how would we have reacted to the 1918 flu if we had viral tests and serological tests? We don't quite know, because we haven't had these tests in a situation like this. So the one thing I can see is that actually we did have a pharmaceutical intervention. We had aspirin that had just come off patent in 1917. So the doctors basically took that as a generic drug and prescribed it, but they prescribed so much of it, it ended up being a toxic dose of aspirin. Just because it's a new drug that looks promising doesn't mean that you know everything about it. And so we're all sort of fumbling in the dark and throwing everything at the wall and seeing what sticks. In that, we've got to remember we're going to make some mistakes. The nice thing about clinical trials is we can structure them so that we make fewer mistakes overall. NPI's work, they're hard to sustain, and 6 weeks was all they could do in 1918. We probably can't do too much more right now, at least for the full shutdown. There's some evidence that ventilators might cause harm in some cases. And we don't need as many ventilators as we thought we did. Again, this is good news, but it means that we were so worried about ventilators, and now the situation has changed. Let's not point fingers about how the situation has changed. It's not the time for that right now. The time for that is to figure out what works to get us back to health as a nation. And don't apply lessons from New York City necessarily for how it spreads in a dense urban environment with a particular demographic. We don't know exactly how that's going to apply to Utah, one of the youngest states with a very young demographic. We've got people working on that right now. The IHME model that predicts when we can reopen supposedly looks at that, but I have to see how it looks at that. And it's a complicated question, and that's one of the reasons why I do believe that the governors are best situated for state by state to figure out where to relax and impose these restrictions. On the other hand, I believe that testing should be supported by the federal government much more than it is. States have a hard time doing something like a big testing program by themselves. So test federally, restrict state-wise, and don't look at the state next to you and tell them how to do it. Let's look at our own state. and let's figure out what works, and then look at the data for how the other states or nations are doing. Two important things we don't know. How will relaxing the restrictions change the R naught? The evidence is that there's no one restriction that will have a huge amount on R naught, so we should pick it, but we should keep in mind that those were in 1918. There could be one restriction that's really important right now, and we take it off and we see cases start to balloon. Okay, then we reimpose it, and then we figure out what other things we can relax. So we need to relax some restrictions, we need to test a lot, we need to see how testing can help us keep the R naught down, and we can also monitor, most importantly, monitoring the hospitals, keeping an eye on that. We're not going to be able to save every life. In some cases, in every case, technically, we're always delaying death, but we can delay some deaths. We should delay every death we can, right? But I am worried about the rhetoric shifting from letting the hospitals serve us the way that they need to versus let's save every life we can right now. That's sort of when you're shifting into focusing so much on one part of a complex situation that you're ignoring the other parts of the complex situation out here. What percentage of our population has already fought this off? And this is coming in right now. Actually, I think this might be my next little podcast, that serological tests are coming in. And the question is, okay, we probably multiply confirmed cases by 10 to 100. And this looks a lot different. If we multiply confirmed cases by 10, in Seattle we're at 2% immunity. That puts us really, really far from 70% immunity, which is the point where we can really relax. By the way, a vaccine can get us that as well. But if it's 100 times confirmed cases, then we have 20% immunity in Seattle. Maybe we should just, right now we want to say the uncertainty, but the serological test will help us see order of magnitude, where are we on this scale? I'm hoping we're closer to 20%, and I'll talk more about that in the next one because data on this is still coming in. I think this is the reasonable range right now, and I think we are truly uncertain where we are between 2 and 20%. Once we come in on the scale, that will have some pretty big impacts on how we relax and what we can do to avoid a second wave. So stay tuned for that. All right, thanks for listening. This is my oldest data update, and hopefully I'll have some new data for you about antibodies on the next one. Until then, let's keep our eye on the ball, keep our eye on the hospitals, hug a hospital worker if there's one living with you. If there's another one, support them, tell them you're praying for them, and remember that people have been through waves like this before, and this is not an easy time to be alive, right? But there's also help out there, and there's some inspiration in that people have gone through this kind of restrictions before. Last thing I got to say, there's a historical issue that in 1918 they shut the churches down, and pastors protested, and there are lots of examples of that. I can point you to a blog post that lists all those things. There were a lot of them. This was a struggle when you have the First Amendment, right of assembly, right of freedom of religion, versus the emergency need to control a pandemic. Churches did mostly shut down in 1918, but again, it was for only 6 to 8 weeks. Let's see how it plays out there, and let's just try to show a little grace to each other in this time when we're all stressed out, and we can realize that God can work behind locked doors and even through screens, but we can look forward to the time when we can actually see each other in the flesh again, because that was created by God too. Okay. I always had to put in a little bit about the church at the very end, because that way you can just turn me off if you don't want to hear that, if you're not in the audience for that. But there it is for my brothers and sisters in Christ. There you go. All right, have a good weekend, and we'll see how that antibody data turns out. Take care of your actual body for now.